presenter for the morning is Dr. Bryce Tierney, and he's going to be giving us an update on cervical cancer. So please welcome Dr. Tierney.
That is not going to be very fun to follow up, so we could just end it right here. So I'm going to talk a little bit about cervical cancer updates. So a little bit is kind of a combination of a couple of talks I've given, and so we'll just kind of get into it because I want to make sure we get out of here somewhat on time. No financial disclosures. So the focus, again, we're going to talk a little bit about the background because I think the background of cervical cancer really helps us identify and understand the screening, prevention, and treatment for it. We'll talk about those basically right there. Just said it. Cervical cancer statistics. This is kind of the one we haven't talked about yet. We talked about ovarian and uterine. Not quite as many cases of cervical cancer as the other two, about 13,240. These are the most updated for what are expected for 2018, with about 4,170 deaths from the disease that occur. Now, again, this is the U.S. Worldwide, cervical cancer is actually a much bigger problem. There are about 500,000 cases diagnosed per year in the world. So this isn't a disease we see quite as commonly in the U.S., and really it has to do with a lot of the screening that we have going on. As far as just survival statistics, 5-year survival overall is about 67.4%, very dependent on their stage. As you can see, early stage has fairly good survival. When it goes to regional spread, meaning kind of next to the cervix or in the pelvis, it's not quite as good, but distant spread is a very difficult disease to have to deal with. As far as the survival statistics, these again talk about localized versus regional, just different way of showing that graph or the information I had before. And then this is the interesting part of it by age. The little red dot, huh? You're right. Oh, there it is. Now I see it. This is a cancer of a younger population with the median age around 35 to 44 years old. So this is a younger population than we are seeing with ovarian and with uterine cancer. So median age of diagnosis at 49, and again, that changes a little bit every once in a while. As far as, again, the deaths, median age is about 57. So the etiology. Etiology is the human papillomavirus. You find human papillomavirus DNA in 99.7% of all cervical cancers. So it's almost pathognomonic to say if you had a cervical cancer, there is going to be HPV in there. This is just a small double-stranded DNA virus, gets into the E6 and the E7 proteins that are really causing the problems. That affects the P53, which we heard from Tracy earlier, and as well as the RB gene, and that is what causes the transformation to cervical cancer. The estimated incidence of HPV is about 5.5 million cases per year. But again, there's only 13,000 cases of cervical cancer. So HPV is quite a big problem with only 13,000 cases of cervical cancer, about 40,000 roughly all HPV-related cancers are diagnosed per year. And again, the average age of getting HPV is 15 to 24. So these are patients that are getting HPV long before they even have cervical screening. So what can we do to help try to decrease our risk of HPV-related cancers in this population who's getting HPV so early? There's over 100 types of HPV, probably over 200 now. We know that there's about 40 of them that cause issues in the anogenital region as far as either low-risk HPV types, which may cause things like genital warts, versus our higher-risk types. There's much more higher risk than I just put here, but these are the important numbers because this is going to be the vaccine type or the HPV types that are affected by the vaccines that are out nowadays. As far as risk factors, first stage of intercourse, number of sexual partners, likelihood the partner has HPV. I don't know the number of cervical cancer patients I talk to them about that this is an HPV-related disease, and they say, well, wait, I have a sexually transmitted disease or do I have cancer? And it is a little bit of a tricky issue because that HPV could have been contracted decades ago. So it is a difficult thing to try to explain to patients when we go down that route. This is, again, just kind of a breakdown of HPV rates per 100,000. And then, again, these are just some of the cancer sites. But, again, cervix is a very high probability that there's going to be an HPV type. It's probably even higher than that 91%. And I'm just kind of getting through these slides because I don't want to go over the 45. As far as the prevalence goes, this is just a couple of work by Dunn. There's a couple of other studies as well that looks at the age of first contracting HPV. So as you can see, the breakdown again in that 15 to 24 year population, a great majority of those that age are going to contract HPV. And then there's that significant increase of prevalence each year from 14 to 24. So what's the problem with prevalence? The definition of prevalence is that it's the percentage of the population affected with a particular disease at a given time. So the problem, like I said, was HPV dormancy, where it will get into these cells and you can actually do a pap test on someone and do co-testing and it'll be an HPV negative co-test. But it doesn't necessarily mean they don't have an HPV virus that's just laying dormant, that with stress or reasons that the immune system isn't working very well, that it can't resurface, become persistent, and make a cervical cancer. And that's the big problem with cervical cancer. It is the persistence of an HPV infection that is very important. So patients who are not getting screening, they have this long persistence that nobody knows they have a persistent HPV infection, and that can lead to transformation of those cervical cells and into a cancer. As far as, persistence, it's important. Here's just a nice little graph. So the clearance, you can see how much of the time HPV will be cleared on its own. You do not need to do something to clear the HPV. The patient's own host immunity will take care of that. And it doesn't necessarily mean that's going to progress on. Now, when you do have this persistence, the longer it persists, the higher rate of CIN3 you're going to see. And CIN3 is just severe cervical dysplasia. And that persistence of severe cervical dysplasia will lead to cervical cancer. And if you can see this breakdown of just CIN3 here, so all these CIN3 patients, it's not, again, not all of them are going to have invasion necessarily. You can see that percentage definitely increases as the years go on with CIN3 persistence, and it will lead to an invasive cancer. So this is a great graph starting way back in the 1930s, and you can see cervical cancer was a much bigger problem back then. And something happened right about there. And all of a sudden, these rates started dropping down. The residents definitely know what this should be, but this is when the pap test was developed by Dr. Papanikolaou, a great Greek physician who saw that if he could sample these cervixes and take a look under the microscope, he can see these abnormal cells. And that was the beginning of one of the greatest, really it is one of the greatest screening not practices, but the U.S. really supported this as one of the best screening institutions, basically, getting this into the communities to have everyone getting their pap test, and we really saw those rates of cervical cancer drop down. So the pap test, about 50%, and this is the problem, I said 50% of women are going to be diagnosed with cervical cancer. They've never actually had cervical cytology. They never had a pap test before. Didn't realize they needed to have one. And this is 80 plus years after the development of it. 10% of them haven't been screened in over 5 years. So we do definitely get worried with some of the new guidelines saying you don't have to have these cytologies for every 5 years, but that does not include the HPV test included with it. It's just looking at cytology only. HPV testing, much more sensitive. And when you talk about a screening test, you want to have a good sensitive test before you start looking to say, okay, is it related to cancer? HPV is a very sensitive test. We can actually see that if someone is HPV negative, it is unlikely they're going to have cervical dysplasia or cervical cancer. But it is not a very specific test. So if someone has a positive HPV test, it does not mean that they have cervical cancer. And those patients tend to get a lot of biopsies if they are only having HPV testing alone, which is why a lot of the times we either do reflex cytology or co-testing, we call it, where we actually get some cells and we're looking at the cells under the microscope to make sure they don't look abnormal, but also checking the HPV out at the same time. ULTS trial, this was done quite a while ago, and this is what at first we had the pap test, but then we started realizing, okay, HPV is one of the major culprits of this. How can we incorporate HPV to try to decrease the number of biopsies and the number of cervical excisions we had to do on these very young patients? And we actually looked at when we had cytology, which was not high-risk cytology, but some atypical cells. We're not sure what these atypical cells mean. A lot of the times these patients were undergoing biopsies and potentially going on to bigger excisions of the cone, which could lead to obstetrical issues for them. And we found that this study actually looked at doing reflex HPV testing after the cytology for these lower risk type of cells that they would find. And if the HPV was negative, it was a very, very low chance that they would actually have any dysplasia or cancer. So those patients could go back into kind of routine screening a year later. HPV testing as the primary test. First kind of started in Canada, and I'm going to be talking about another Canadian trial here in a little bit. But they did look at HPV versus conventional Pap testings. And again, they were looking for sensitivity and specificity. They must do it better in Canada because they actually had a really good specificity here. But again, a lot of the times this HPV does go on to getting reflex cytology, meaning they're looking at the cells as well, not just the HPV. Because HPV alone, again, isn't very good. And I'm going to show that. Oh, Amsterdam kind of did the same thing there. The Athena trial was a big one by Tom Wright. And this was looking at HPV. And there's two phases of it. One, they wanted to confirm, yes, HPV is very similar to what we've seen in the past, that women at the age of 15 to 24 are the ones that are being diagnosed with it. But how can we use this information to improve our screening? And this led to another trial that looked at, basically it was 10 different screening strategies, we'll say. This was the ALTS trial, basically, the first one that they did, which is what kind of the majority of people were doing at the time. Cytology alone, which was before the ALTS trial. Don't worry about a lot of these. It's just different ways of using co-testing. I'm going to go through that. And then again, different ways to do HPV testing. Now, we do something called genotyping with HPV because, like I said, there's some low-risk HPVs, which may not necessarily go on to prevent or to make a cervical cancer, but it could falsely make it look like, well, this person has HPV. Now they need to have a biopsy to show if there's any dysplasia or cancer that's there. So when we do genotyping, we actually break it down to high-risk types of HPV versus the low-risk types, and we're doing it even more by breaking it down to the exact HPV serotype. So 16 and 18, we know, cause 70% of all cervical cancers. So those are probably a little bit more virulent. So with those, we thought, well, what if there's a 16 or 18 positive? Maybe we do need to look a little bit more closely to see if there is actually risk for cervical dysplasia here that could proceed on to a cervical cancer. So lots of this, and this is a, don't even worry about looking at this graph. But basically, his whole point of it was looking at this column right here. The point of it is that colposcopies, yes, colposcopies are great because they will diagnose if someone has dysplasia or they'll diagnose if someone has cancer, but does everybody need to have a colposcopy? So the negative outcome of this study was looking at how many colposcopies are done. In HPV alone, there was more than double of any of the colposcopies. So we know HPV alone necessarily isn't good, but if you can use some strategies by improving your sensitivity, decreasing your false positive rates, get through that, then you can come up with these strategies that might balance the sensitivity and specificity of these tests. And the whole point of all this last like 5 to 10 minutes was that in August they actually released some new screening strategy guidelines. And the U.S. Preventative Task Force Services released these. I'm going to get through that to that screen right here. So women under the age of 21 did not get any screening anymore. And the big problem with this is, like I said, the 15 to 24-year-olds are the ones who are at highest risk for getting HPV. A lot of those patients are getting HPV, but we know that their immune systems are working really well and they're going to clear it, that we are doing a lot of leaps, which means a resection of part of the cervix, and finding very little cancer there. So that's why this age kind of recommendation went up. Now again, it's a recommendation of a D category. So I think you definitely need to kind of, it's more of guidelines than actual rules. But when you start looking at women age 21 to 29, age 30 to 65, there is a lot of data here to support that. These women who are 21 to 29 are much more likely to have HPV. So if we're testing for HPV, it's going to lead to a lot more biopsies. Maybe it will see disease there, but their own host immunity would likely have cleared it. And when you get into the HPV alone, so at the age of 30 to 65, these are patients who are more likely to have more of a monogamous relationship. They're probably going to be at a little bit of a low risk. That's why they started extending out these dates. Start using HPV. Like I said, it's the persistence of an HPV infection. So if someone is in a very monogamous relationship and they don't have a lot of issues with their immune system, they're not on chronic steroid use, they don't have HIV, they're not on chemotherapy. Pregnant patients, their immune systems are very low and they tend to get a lot of cervical dysplasia. You can actually extend that time period out farther and farther. And like Dr. Morris had mentioned before, we see a lot of not necessarily oncology related. This is kind of the pre-invasive side of what we do. So I do get a lot of referrals for abnormal pap tests. And a lot of the times I will see where a patient has a pap test, and then they had a pap test 4 months later. And they had a pap test another 4 months later. And then they had a LEEP done maybe, and then another pap test 2 months later. And they're so scared of finding an actual cancer that we might be doing more harm than good. So that's why these recommendations from both the U.S. Preventative Task Force Services as well as the ASCCP, which is the American Society of Colposcopy and Cervical Pathology, we really like to follow those rules so we don't do more harm than good here. This is going to be my daughter when I have to give her the vaccine. Our son is great. He's like a trooper. He's like, here you go. My daughter just goes crazy with these things. But the HPV vaccine era, talk a little bit about this. So here's kind of the FDA approval outline for the HPV vaccine. So it was first in June 2006, approved for girls and women between 9 and 26. In October of 2009, so it took 3 years before they said, maybe we should have the boys be vaccinated as well. That whole little bit of herd mentality. As well as we do know there are HPV-related cancers that will affect men. So why not give them HPV vaccines as well? In December 2014 and 15, again, it was a little bit delayed for the boys. They did approve Gardasil 9, which were those extra high-risk subtypes I talked about on that first slide. So those are the 9 different HPV serotypes that are now currently available for vaccine. And it's up to the age of 9. Now, they always stopped it at 26. And the tough one I always have is maybe someone who has a cervical cancer and their daughter who's 28 is in my office and says, well, should I get the vaccine? And I have to say, well, you know, the FDA doesn't really recommend it after the age of 26. The thought process was maybe it's you don't quite have that same immunity after the age of 26. Probably more realistically was that the initial trials that looked at this ended at 26 rather than anything higher. But we know it probably is helpful, and I have recommended certain patients who maybe have a long history of dysplasia. I'm like, if they want to get the vaccine, I don't see necessarily an issue with it at 27 or 28. And last week, FDA just approved it for men and women from 27 to 45. So there might be a couple of people in here who are under the age of 45 who thought, oh, I was too old to get the Gardasil vaccine, but now you actually can. And people always ask me, well, should I get the Gardasil vaccine? Well, you know, the question is do you already have some serotypes of HPV? It's very possible. Like I said, it's such a high incidence in the US of having HPV. But there are many, many different types of HPV that can cause cancer. So maybe your body is not exposed to a particular serotype. So I think it is probably reasonable here. So that is kind of one of the biggest updates that just happened. This is actually the percentage of adolescents who are up to date on their HPV vaccine. It's a lot better than it used to be. About 5 years ago, the rate of boys having all 3 vaccines, because it is a series of 3, there's questions if you can do it with 2, was around 15 to 20%. Really bad. Girls, it has always been a little bit better. They always have a little bit of a higher risk or a higher coverage than the boys do. We actually do a pretty good job in Nebraska. Not quite as good as they do over here in the East Coast. And Rhode Island actually did make it a mandated, not pre-kindergarten vaccine, before 6th grade. They had it as a mandated vaccine for all 6th graders, basically. A lot of the data from this of you know, making it a required vaccine actually came from Australia. Australia had a very large issue with genital warts. Like very terrible, where patients were getting hospitalized very badly for this. This is why 6 and 11 were actually added into that. Australia mandated everybody get it, and their rates of hospitalizations from genital warts dramatically dropped. We've already seen in the US that there has been a decreased number of severe cervical dysplasias diagnosed on biopsy in the US as well. Now again, I said it's a persistence of an HPV infection. So people are like, well, this came out 12 years ago. We're not seeing any drop in cervical cancer rates. This isn't working, obviously. But it's that persistence. My hope is that this will continue to drop over time, and maybe we will start seeing a decrease in the actual incidence of cervical cancer in the future. Biomarkers. Biomarkers are interesting. This is probably going to be a lot more important in the post-vaccination era too, because we are going to start having these biopsies performed when people have an HPV vaccine. They're up to date on their HPV vaccine. And I have seen someone with cervical cancer who had their HPV vaccine before. So we can actually use it to improve the detection of cervical cancer and cervical dysplasia. If you ever go and sit in on a PATH conference talking about Pap tests and talking about cervical biopsies, it's really subjective. It is extremely subjective. And if we can find better ways to actually say which patients may have a higher grade lesion that is going to persist on to becoming a cervical cancer, that would obviously change our algorithm on how that patient should be screened. So some biomarkers like P16 actually is being used a lot now. So I will see a cervical cancer biopsy where they'll say, yeah, P16 stains diffusely positive. Makes me a lot more nervous if they only called it severe dysplasia versus if they said it was an invasive cancer. They're kind of confirming it. Ki-67 I don't quite see as much, but when it's used to P16, it just improves the sensitivity and specificity of identifying cervical dysplasia that's higher. So again, yes, it can be subjective, but if a patient has a biopsy that maybe it's CIN2 or CIN3, but Ki-67 and the P16 are completely negative, they're probably at a lower risk. Then if it's positive, we need to make sure that we educate that patient, because the big thing about cervical cancer is compliance. Like we said, greater than 50% of people with invasive cervical cancer have never had screening done before. CMIC, this is kind of newer. Again, just indicates that it's a poor prognostic indicator, and the likelihood of progression is increased. This is what we call a transition slide. And some of these slides I'm going to thank Dr. Morris for. He gave me these for a talk I did a while ago. This should not be papped, ever. It is a lesion. A pap test is a screening test. A screening test is there are no signs that a patient has a problem, and that is a problem right there. So there is a maybe 10% of the time, I'm going to say it's probably less. Dr. Morris would know this better. But I will still see where someone had a biopsy of cervical cancer and they had a pap test of that big mass, 4-centimeter mass that was pap test. And it comes back negative because it could be just necrotic cells that it's picking up, and the pathologist doesn't see any abnormal cells because they all washed away. So you do have to definitely be careful when you see an abnormal lesion that you wouldn't pap that. And this transition slide tells me I'm going to start talking about treatment. So treatment for cervical cancer, which I kind of think is more interesting than the screening of it, even though I spent a lot of time on that. I'm going to talk a little bit about cervical cancer staging here. So just like any cancer, stage 1, 2, 3, and 4. Stage 1 means confined to the cervix, whether it's a microscopic disease, meaning a stage 1A, or something you can actually see, which is a 1B1 or a 1B2, depending on how big it is. These are more often going to be from pathologic staging. So these are biopsies that are done. They have specific measurements that we're looking at to say whether it's a 1A1, a 1A2, 1B1. 1B2s are a little bit more clinical, but you are getting some kind of pathology. But for the most part, cervical cancer is clinically staged, very different from the other staging we have for our other cancers. And the reason is you do not want to operate necessarily. Well, you definitely don't want to operate on a 2B, but a 2A you potentially could. But you don't necessarily want to operate on a patient who has more advanced disease because you are probably going to worsen their prognosis. And every once in a while, we'll still see somebody who had maybe some pre-invasive disease on a biopsy and went straight to a hysterectomy, and now they have a cut through, meaning that they went right through tumor. And their prognosis probably is a little bit worse. So we do like to educate, and not necessarily patients, but also physicians about, okay, what are the proper ways that we need to identify this as a cervical cancer? And this is the whole reason of why we clinically stage this. Stage 3 is 3A is broken down into how far down into the vagina it can go versus out to the pelvic side wall. And a lot of the times we'll get CT scans on these patients who have cervical cancer, and we may see some dilation of the ureter because it's getting pressed against the pelvic bone there. So that automatically makes them a 3B. And then 4A disease is when it's either going into invading into the rectum or the bladder versus peritoneal disease. These are not lymph nodes. Lymph nodes have nothing to do with the staging criteria. It's a trick I always get my residents on. Whether or not they have positive lymph nodes does not change their staging because, again, it is a clinical stage. This is peritoneal disease is what they're trying to show there. So again, it's clinically staged. These are some of the things you can do for clinically staged. I remember getting tested on, okay, what can you use for clinically staged and what are you not allowed to use for clinically staged disease? CTs you actually technically can't use. Sometimes you don't need a CT scan to see that there's a problem right there. Another great picture from Dr. Morris. This is a supraclavicular lymph node that's enlarged in a patient with cervical cancer. So they likely have disease that started down in the cervix, went to the pelvic lymph nodes, up the para-aortic lymph nodes, and finally over into the left side of the neck here. This is easily biopsied with a fine needle aspiration. Cervical biopsy, of course, is very important to know that there actually is invasive disease. You could do endoscopy, such as looking in the I don't know if anyone's ever done hysteroscopy for cervical cancers. That was in the book. But cystoscopy and proctoscopy I've done before. If a patient has any bleeding in their stools or bleeding in their urine, you want to see if there's actually disease invading down. Imaging studies, these are the allowed imaging studies, but I don't know of a single cervical cancer patient that has more than stage 1B1 disease that does not get a PET scan nowadays. So majority of these patients will get PET scans because that could potentially change their treatment, and I'll explain why with a couple of things here. So when I think about treatment for cervical cancer, the biggest things that go into my head is, okay, what is the stage? What is their desire for fertility? Because that could change things. Other things that go through my mind, tumor volume, what medical comorbidities do they have? Do they have known lymphatic spread, which we will see on PET CT scan? What's their age? What's their body habitus? Stage 1A1s, again, you actually can treat this with a cone. So this is already fertility preservation right here. You have a 28-year-old who has a 1A1 cervical cancer. You can do a cervical cone on them, and they're cured. You don't need to do anything else. You don't even need to do lymph nodes on these patients. And they can still go on and carry a pregnancy and probably not have much of a problem with it. If someone's older and doesn't want to have any kids any further and there's a 1A1 disease, it's reasonable to do a simple hysterectomy is the other thing we call an extrafascial hysterectomy, just the normal hysterectomy you usually think about, where you just remove the uterus, the tissue between the cervix and you remove the cervix away from the tissue that's right next to the cervix, which is called the parametria. And I'll explain the difference between that and a radical hysterectomy in just a second. Now, when you start having disease that is potentially has the risk of spreading outside of the cervix, that means disease that has LVSI, which is lymphovascular space invasion. When you start having higher stage disease, now you definitely need to consider a radical hysterectomy in these instances. You are trying to get around the tumor and show that the tissue that is next to the cervix, called the parametria, doesn't have any disease in it, because that could change how you need to treat that patient after surgery. The whole point of doing a radical hysterectomy should be that you're trying to avoid radiation therapy, okay? When you start having disease that's a higher stage, a 2B or a 3B, you're going to cut right through tumor, and you're not going to be able to give the doses of radiation that are going to adequately potentially cure that patient. Because of the way that cervix sits in there, the radiation oncologists actually use that cervix to protect the bladder, protect the bowel. They can give higher doses of radiation to the cervix. Once you remove it, they can't quite get the dose fields that they really need to adequately cover all that area. So when we talk about radical hysterectomies, we are looking for reasons that they're not going to get radiation. Because if I can do a radical hysterectomy and it's a small enough tumor, they don't need radiation therapy. You'll see a couple of overlaps here. 1B2 and 2A is in the radical hysterectomy, and the 1B2 and 2A is here for consideration of chemotherapy. And this is actually the NCCN guidelines. They have it in both, because it really does depend. If you have a small tumor that is encroaching just a little ways onto the vagina, yeah, technically it's a 2A, and that's probably a different disease than a 6-centimeter bulky tumor with disease a third of the way down the vagina. So I think we will look at that and say, well, this patient is likely going to need some radiation. Why would I do this large surgery on them? Because they're probably going to be getting radiation anyway. And then the 4Bs. These are very difficult. We already saw from the beginning slides that their overall survival is very low. This is when you would consider what's called palliative chemotherapy. Again, palliative meaning we're not necessarily going for a cure. We're trying to palliate symptoms. It is lower likelihood that we're going to get to a cure. Not to say it's not impossible or someone hasn't had this done, where they actually did have very, very good responses, but we worry that chemotherapy alone isn't going to completely cover it. I always recommend a clinical trial if one is available. It's not unreasonable to consider best supportive care. And unfortunately, I've seen patients who are maybe very elderly, have a lot of issues, where necessarily they couldn't get chemotherapy, where they have had to go directly to best supportive care. Because we are looking for not doing futile things to patients either, where we're doing something just to do something, even though they won't be able to tolerate it. We want to make sure we give them the best care we can. This is a great picture, and Dr. Morris will recognize these two. So this is the simple hysterectomy, and the radical hysterectomy has this extra little bits of tissue on the side here called the parametria. A little bit more of the vagina because we're looking for spread of the cervical cancer, and we actually take a little bit more of what are called the uterosacral ligaments behind there. I don't know if this is when I was a resident, but with Dr. Morris, the resident always stands on the right side. Somebody was a little overzealous. It might have been me. I don't know. They ripped that ovary right off of there. Now, ovaries aren't necessarily, you notice I never said anything about the ovaries yet as far as treatment. Cervical cancer rarely goes to the ovaries. About 1% for squamous cell cancers, maybe 2% for what we call adenocarcinomas, just the different histology types. So you do not necessarily need to remove the ovaries in someone if you have a 35-year-old with a cervical cancer. You do not need to make them go into menopause. It's not going to benefit their cervical cancer prognosis if you take those ovaries out or leave them behind. Fertility preservation. This is one I'm a little bit passionate about. I work a lot with the reproductive endocrinologists, and you kind of wonder, well, how can I remove this area in somebody and they can still carry a baby? The cervix is completely gone there. Part of the vagina is gone. Like, it's completely separated. How are you supposed to do this? So we can actually do something called a radical tracheolectomy, which is essentially doing a radical hysterectomy, but sparing the blood supply that go from the gonadal vessels here to the uterus here. We take all of these vessels from the uterine artery, just like we normally would with a radical hysterectomy, take a little bit of the vagina as well, and then we actually just cut the cervix right off of the uterus there. We send this to the pathologist, so he can tell me that, yes, there's no positive margins on the highest level of the cervix that there is. They try to tell me, okay, do you see any cancer? If there is, you try to go a little bit higher. But then you can put a cerclage in here because the cervix is now gone. It cannot hold a pregnancy, but you can put a cerclage there in an attempt to that later on, if they get pregnant, they'll be able to carry that child as well. And then you reanastomose the lower uterine segment of the uterus to the vagina. Here's some pictures from Ohio State, actually, this time. So this was actually an open. I've done this robotically as well, but you can see the uterine vessel here with the parametria by the cervix. Here is the uterus, and the ovaries are going this way. This is where you have the uterus. The fallopian tube is right there and there. The vagina is down here, and the legs are going this way. And this is the reanastomosis of the uterus to the vagina. And you can see the cerclage is right there. And this is what it looks like afterwards. It almost looks normal after you get done with everything. We've done 3 of these here so far. One person, we do remove lymph nodes at the time, and I do everything I can to make sure we don't have any lymph nodes involved. We get PET scans and I get MRIs. And unfortunately, this patient had a very small amount of cancer in one of her lymph nodes. So unfortunately, she did have to go on and get radiation afterwards. I do have another patient, however, who had a 35-weeker a year ago, I think, maybe. And she did not need in vitro fertilization to get pregnant. She got pregnant on her own and was able to carry the baby to almost full term. So it definitely does work. And this is the information from Maria Plant. Looking at the obstetric outcomes are pretty good. A lot of them will go on to at least a 3rd trimester, and a lot of them will be full term. And the oncologic outcomes are very important as well. A lot of my patients come in and they're like, I don't care if I can have a baby, I got to make sure I'm going to be alive in 2 years. But you can see the oncologic outcomes are identical. They still have a low risk of recurrence rates. So when I can tell them that, listen, I can make it so that your prognosis is going to be the same whether or not you keep that uterus in place, but you could potentially, could be issues with it, but potentially still carry a child, they're definitely more interested in that. We do have to make sure we are looking at risk factors that aren't really high in those patients. I want to give them the best opportunity to have the best outcomes, and we do know that when you have larger tumors, the presence of a lymph vascular space invasion isn't necessarily contraindicated in it, but it does make me a little more nervous when I see that. But it is a lot of counseling because it's not only the oncologic outcomes we need to talk about, but the obstetric outcomes as well. Radiation versus radical surgery. Basically, there are equivalent rates for stage 1 and 2A disease, up to 2A disease, which is why that 1B, 2, and 2A are included in both sides because they are going to have equivalent rates. So when I do have a very elderly patient who may not tolerate the surgery as well, when you do have patients who are super morbidly obese, you definitely have to worry about how well am I going to be able to dissect a field, get a good lymph node dissection, have a good radical surgery to make sure I get around this tumor that they're not going to need radiation afterwards anyway for, and occasionally that does happen, unfortunately. So it is definitely tailored when you have to see the patient and their particular issues that they may have, their age, the size of the tumor. So a lot goes into this. So this is an interesting 2 cases I had. They're very, very similar. You have a 33-year-old who had some postcoital bleeding. Exam showed a 3-centimeter mass. She had a biopsy which showed it was a squamous cell carcinoma. Her PET CT was completely negative. She underwent a robotic-assisted radical hysterectomy. One of the updates I hesitate to talk about is if we can still do robotic radical hysterectomies. There is some data coming out that we're going to have to look more closely at if we're going to have to revert back to exploratory laparotomies, and some of my attendings at Ohio State are going to tell me I told you so. This patient did have some pathology though here, and when we look at the pathology afterwards, again, I said we want to try to avoid radiation in these patients. However, we know that there are certain characteristics that put her at a little higher risk for needing radiation. And that particular patient did meet those. We look at the size of the tumor, the depth of invasion, and whether or not there's that lymph vascular space invasion. And you'll notice that one keeps popping up a lot. It's definitely a risk factor for recurrence. So these patients probably would benefit from getting some radiation therapy. Other things like positive margins, lymph nodes that are positive, or that parametria tissue being next to the cervix being positive is a little bit of a high risk. So they actually get a little bit consideration for a little bit more treatment. They're usually getting chemotherapy with their radiation therapy and potentially chemotherapy afterwards as well. The other case here, a 37-year-old, persistent disease here. She had cryotherapy 7 years prior, ascus pap in 2013, but had no other follow-up after that. So she presented with abnormal bleeding and a discharge. A cervical mass was seen and biopsied. She had a PET scan performed. Now she must have had some inflammatory bowel here. But this is the bladder kind of lighting up because basically a PET scan is just radio-labeled sugar molecules, and the bladder filters that out. But you can see right here there's a very black spot, and right here there is a very black spot. And those represent lymph nodes. So she had a pretty large lymph node in the pelvis, and another one a little bit lower down here. So we actually needed to resect that lymph node out. I did not remove her uterus or cervix though, because she is going to require radiation therapy. The reason I removed that lymph node was radiation wouldn't cover the size of the lymph node that was there adequately enough. So you do have to get that volume down a little bit so radiation can do its job. She went on to get cisplatin and external beam radiation, high dose vaginal brachytherapy, and then consideration for adjuvant chemotherapy because of those lymph nodes being positive. And this is a case just to show I do remember to take pictures sometimes, and this is one of the most pleasant patients I ever had, and she had just a very, very odd clinical course. She was diagnosed with a 2B cancer, again, clinically staged. She had disease out into the parametria. She underwent concurrent chemoradiation and did great. She had a great response to her tumor. She underwent a side implant for brachytherapy. Just because they were worried about a little area on the right side on an MRI. When I saw her afterwards, she had no obvious disease at all. The entire vagina and cervix looked normal. She fell and hit her abdomen 3 months later, upper part of her abdomen. She developed a little hematoma there, and it just kind of persisted. And she noticed this mass was there, and she talked to her primary doctor, and they said, well, that can happen when you hit your abdomen. Continued to persist. She went and saw a general surgeon who looked at it. He said, well, it looks kind of funny, let's get a biopsy of it. Got a biopsy of it, and it was consistent with metastatic squamous cancer. So sometimes these cervical cancers are tricky, and you can't predict them. And this, unfortunately, was right under her on the left side of her torso there. This was kind of an area between the breast, and unfortunately, this was her PET scan. We attempted to get her to palliative chemotherapy, but unfortunately, this disease was fulminant for some reason. I can't explain it why, but we occasionally see these with cervical cancers where they're just hyper-aggressive. And unfortunately, she passed away very quickly after that. I think it was in August. So that brings me to the treatment for recurrent cervical cancer. And I'm going to try to get through this really fast. We basically have not come the longest way in treatment of recurrent cervical cancers, especially if someone's already had radiation before. We've added bevacizumab, or Avastin was the other name we talk about it. And we have improved their survival somewhat, but it's still not the best at 17 months. This did actually lead to the FDA approval of bevacizumab, and this was about 4 years ago. And this was at the, actually right, that might have been my first surgery date while I was here at Methodist. But we knew the results from 240, and people had started using Avastin in these patients. Brings me a little bit to Keytruda, some of the newer stuff coming down the line. Keytruda, you'll see the commercials on quite a bit nowadays, and it seems like it's working in almost any type of a cancer. They use it for ovarian, we're talking about it in endometrial, renal cell, colon cancer, we're using it quite a bit. Anything that may have some microsatellite instability, or this PD-L1. PD-L1 suppresses the immune system, and the thought is that cancer cells can get out of control like they do because they're suppressing the natural immune system that can't fight it. So if we can give pembrolizumab, which helps block that, maybe we can ramp up the body's own immune system and it can fight off some of those tumors. And there's been fairly good results from that. This is Keynote 158 that looked specifically at cervical cancer patients. Now, when I say some good results, unfortunately, that only means a response rate of 14%. It only means a complete response rate of 2.6. So basically, 2 people had a response. And a couple others had a partial response. But again, we don't have very good treatments after the initial upfront chemotherapy for recurrent disease in a radiated field. On the horizon, we are looking at things like infecting patients with listeria. People think I'm crazy when I tell them about this, but what happens is that you're using these deactivated listeria, and it's actually introducing HPV DNA into the body's system. You can combine that with PD-L1 inhibitors to ramp up the immune system. And the thought is that if the body sees these HPV DNAs as foreign and you ramp up that immune system, maybe it'll fight off those tumor spots and make them shrink down. So we've had some fairly good results with that. We're looking at PARP inhibitors. Cediranib is another, it kind of works like bevacizumab a little bit, but we're looking at clinical trials into there. There's a lot of stuff still in the works as far as cervical cancer, but the biggest thing, and the whole reason I put all that screening and prevention stuff in the beginning is I think one of the best ways to stop cervical cancer is the prevention of it. So I'm a big proponent for HPV vaccines. My son is 9. I'm waiting to see if the pediatrician is going to recommend it or not. I'm kind of like anxiously awaiting his next visit to say, oh, is he going to recommend Gardasil? Because there's no Gardasil posters up, so we'll see what happens. But he actually is going to. We've already talked about it before. But that's the thing is you don't have a lot of girls or boys that are going to an OBGYN who this is on their mind a little bit more. They may not see an OBGYN until maybe are like, okay, now I'm in college, I'm away from my parents a little bit more, I should probably get some birth control pills. And then they start talking about it, and maybe it's already too late. They've already contracted HPV, the virus, at that point in time. So I'm a big proponent for it, and I think that's it. And I got a lot of references. Any questions? Sorry, that's so fast. Yeah?
Thank you for the excellent talk, Dr. Tierney. Just a quick question. Is there anything specific as far as pap smears or any type of screening for HIV positive women?
Again, yeah, so all of those guidelines that the U.S. Preventative Task Force Services comes out with, or ACOG comes out with, American Cancer Society has their own outline. I mean, we have like 5 different types of guidelines to follow as far as pap tests go. For anybody who's immunosuppressed, not necessarily HIV patients, but lupus patients who are on chronic steroids, transplant patients who are on constant immunosuppression so they don't start having reactions against their transplanted kidneys or livers. All of these patients are at a lot higher risk for it. And you should be doing pap tests not necessarily like the guidelines recommend, and that's why we always call them guidelines. It's not strict rules. So you definitely want to do it a case-by-case basis. If a patient has had a history of cervical dysplasia and they had an HIV infection, I would PAP that patient every year, and without question. I wouldn't hesitate to do that. So yeah, they are a little different, and that's sometimes where when we are using those, if someone is like, oh yeah, I'm going to do that for every single patient, no matter what, I'm not going to screen too soon, that is where you can get into trouble, where it is going to be the zebra patients who maybe don't quite fit into those algorithms quite as well anymore. Maybe that's not quite as reasonable to consider a 5-year PAP test in someone who has HIV with a history of cervical dysplasia. Absolutely.
And the HIV-positive patient may not be able to respond to the HPV vaccine as well either, right?
Yeah, for as far as the HPV vaccine, absolutely. If someone was coming to me to say, hey, I want to have Gardasil and have HIV positive, and they have a high viral load and their T4 count, I don't see the point. I don't know that they will be able to mount an adequate enough response to that. Now, if they get on treatment and their counts go down and their T cells are adequate, yeah, absolutely, I think they could have that. I don't see a reason why. All right, thanks everybody.